Welcome to the deep dive. If you're tuning in, chances are you're either knee-deep in the most demanding shift of your life, or, well, maybe it's just another Tuesday for you. You're working in that unique environment, the level 1 ED. It's a real pressure cooker, isn't it? Polytrauma rolling in, potential STEMIs, stroke alerts firing, and somewhere in all that managed chaos, you've got to execute precision medicine on, well, the quiet killer that often just walks through the door. Sepsis.
That's so true, sepsis. We talk about it all the time.
Right.
But, so often those conversations end up being about what went wrong, who missed something, who was slow on the fluids. We want to flip that today. This is really about recognizing just how tough that level 1 setting is and honestly celebrating the preparation that lets you succeed against sepsis.
Exactly. So our mission today isn't just running through a checklist. It's about really digging into the official evidence-based battle plan, the Hour 1 Mundle. But we want to look at it from our perspective, peer-to-peer. Unpacking the why, the physiology behind every single thing you have to do in that, let's be honest, brutal 60-minute window.
Yeah, the physiology is key. It's not just knowing what the steps are. It's understanding why that lactate is high, why we're so rigid about cultures before antibiotics, why we're pouring liters of fluid into someone who sometimes, frankly, looks like they're already fluid overloaded. We get the pressure you're under, these sepsis alerts, the clock ticking down from 60 minutes. That's a fairly new layer of pressure for many of us. And yeah, sometimes we've got that amazing ED pharmacist right there, maybe 40 hours a week, ready to help mix Vanoc or Zosyn. But at the end of the day, when they're not there, or even when they are, the patient's outcome, it really hinges on your judgment, your assessment, your hands-on execution.
Okay, so let's start right there with the mindset. This is crucial. In a level 1 ED, we see severe illness constantly. It's what we do. But sepsis, it's different. It's not just another diagnosis on the list. It's like a full systemic declaration of war by the body against itself.
Right. The source material we're looking at makes a really sharp distinction here. You've got sick patients, and then you have septic patients. Think about, say, a 25-year-old, otherwise healthy, comes in with straightforward community-acquired pneumonia. Okay, they're sick. Maybe they need some oxygen, some antibiotics. But their body's response is generally appropriate, contained. They probably stabilize, maybe get admitted, maybe even go home soon.
But the septic patient, oh man, that's someone whose body has just completely lost the script. Their reaction to the infection has gone haywire. It's so dysregulated that the infection itself triggers this massive systemic inflammatory response SIRS, and suddenly the immune system is attacking the host. They are, quite literally, circling the drain.
And critically, like you said earlier, these are often the ones who sneak up on you. They aren't always the big, dramatic polytraumas with obvious, injuries that scream, I'm dying, blah, blah, blah. The source material kind of colorfully calls those the ones with tombstones big enough to sit on. No, the septic patient. It might just be the nursing home resident who's suddenly confused.
Yeah.
That's the only change. Or, 45-year-old, maybe a few days post-op, who just looks a little pale, a little off.
Yeah, and time is everything here. We have to internalize the sheer speed of the physiological collapse. Time isn't just muscle in trauma. In sepsis, time is literally every organ system starting to shut down simultaneously. The source uses this really intense, almost scary analogy, but it nails it. It describes the body in septic shock like this. All the faucets are wide open, the kitchen is on fire, the walls have ants in them, and the AC vents haven't moved air in days. It's visceral.
It really is. And it captures that multi-system failure perfectly. The open faucets, that's the massive vasodilation, the loss of vascular tone. The fire, that's the raging systemic infection. The ants in the walls, that's the cytokine storm, that overwhelming inflammatory cascade. And the AC vents not moving air, that's the critical piece. Tissue hypoperfusion, cellular starvation, which, as we'll get into, is exactly what we measure with that lactate level.
Okay, so fighting that level of chaos, the success doesn't come from some sudden, brilliant diagnosis. It comes from preparation. Honoring that prep. We're talking minutes, sometimes seconds making a difference, which is why that image the source paints is so powerful. The prepared nurse isn't the one with, a cute daisy on the desk. It's the one who already has 2 grams of Vanicus, vial popped, draped over the keyboard. That's not being dramatic. That's efficiency becoming a life-saving action.
Absolutely. And that preparation, it starts before any order is even written. It starts at step 0. Trust your gut. Think sepsis. The clock, that crucial 60-minute clock, doesn't start when the sepsis alert officially fires in the EMR. It starts the second you, the nurse at the bedside, suspected. You were the first line of defense.
And sepsis can be so sneaky, can it? Especially with the complex patients we see in a level 1 setting. We look for the classic signs: fever, tachycardia, hypotension. But we have to be just as tuned in to the atypical stuff. It's not always the 90-year-old with a UTI and a temp of 103. It could easily be the diabetic patient whose temp is only like 99.8, or the patient on immunosuppressants whose only complaint is just feeling vaguely unwell.
Or, and this is a huge one, that new onset confusion. Acute mental status change in someone with a known or even just suspected infection source. Even if their blood pressure looks okay, maybe just borderline low normal for them, that change in mentation, that's an emergency. The brain is so sensitive to poor perfusion, it's often the first organ to really show you something is profoundly wrong.
So to help catch that, we have tools like the Modified Early Warning Score, the MEWS score. It's useful, right? It formalizes things a bit, pulls together BP, heart rate, respiratory rate, temp, and importantly, that cognitive status piece. If someone's really sick, that MUWS score should climb. It should theoretically yell at you before they visibly crash hard.
It should, and it can be a helpful flag, especially maybe on the inpatient floors. But I might, offer a slight counterpoint for our specific level 1 ED environment. We see patients who are incredibly complex, masters of compensation sometimes. MEWS is a good safety net, but I wouldn't rely on it solely. Your clinical judgment, the experience you gain seeing critically ill patients day in, day out, that has to be paramount. It often picks up subtleties the score misses.
I couldn't agree more. That gut feeling is real. If you've got a patient, let's say they have known cellulitis, or maybe a nasty abscess they're waiting for drainage on, and their vitals are technically okay, maybe heart rate's 95, BP's 105 systolic, but you look at them, their color's off, they look clammy, maybe their cap refill is slow, and you just get that feeling in your stomach like something isn't right here, that intuition. That's gold. You have to act on that suspicion. Raise the alarm. Don't wait for the BP to formally hit below 90 or the MAP below 65 to validate what you're already seeing. Waiting costs lives. Remember that 7 to 8% mortality increase per hour of delay.
Exactly. That feeling that I don't like how this person looks, that's the highest form of preparedness kicking in. But once you raise that flag, once you think sepsis, you kind of have to lock in. Tune out the background noise of the department, try to manage the family's understandable fear, and just begin executing the hour 1 bundle. Systematically, simultaneously.
Okay, the clock is definitely ticking now, loudly.
Yeah.
We've recognized the enemy. Now we hit phase 1 of the formal bundle. This is all about diagnosing the severity and getting the access we need to fight back. It happens all at once. Starting with bundle step 1, measure a lactate.
Right, the lactate. And this isn't just, another lab value to check off. This is our immediate snapshot of how much cellular damage is happening right now. We say it's the waste product of tissue hypoperfusion, which is true. But let's really break down the why for everyone listening. What's happening inside those cells?
Yeah, let's get into the mitochondria, the cell's powerhouses. Normally, when cells have plenty of oxygen, they use aerobic metabolism. It's clean, efficient, makes lots of ATP energy. But in septic shock, that systemic inflammation, the vasodilation, the leaky capillaries, it all leads to profound hypoperfusion. Tissues aren't getting enough oxygen, they're starving.
So the cells panic. They switch to this backup plan, anaerobic metabolism, sometimes called the Pasteur effect. It's like a desperate chemical scramble to make any energy without oxygen. But it's incredibly inefficient, and worse, it produces nasty byproducts, namely hydrogen ions, which cause acidosis, and this huge surge of lactic acid. Anything over 2 millimol is generally considered elevated and concerning in this context.
And the implication there is huge. The cells are suffocating. And that lactic acid, it's not just sitting there, it makes the blood acidic. That acidosis starts messing with everything, enzyme functions, how well medications work. Critically, it can actually depress the heart's ability to contract, making the shock even worse. So a high lactate, it's a direct measurable signal from the tissues yelling, "Help, we're suffocating, we need oxygen."
Precisely. So that initial lactate level, it's our baseline. It tells us the extent of the cellular debt the patient is carrying right at this moment. And pretty much everything we do next, the fluids, the antibiotics, maybe pressors, it's all aimed at clearing that lactate, paying off that debt by restoring oxygen delivery.
Which leads us right into the next part of phase 1, bundle step 2, stabs and labs. We need the tools to fight this war that means access, and it means information from the labs.
Access first. It's non-negotiable. You need minimum 2 large-bore peripheral IVs, think 18 gauge, even 16 gauge if you can possibly get it, and the veins support it. Why 2? because we're anticipating needing to give massive fluid volumes, maybe blood products later, and potentially run multiple IV medications at the same time. One line just won't cut it.
And let's be real here, in the ED, getting those lines can be the first major battle. The patient might be peripherally shut down, cool, clammy, veins are collapsed from the vasoconstriction. Sometimes you're grabbing the ultrasound just to find a vein deep enough for an 18. That skill, getting those two big lines quickly in a crashing patient, is huge. And what if you only get one? You don't just stop. You immediately start advocating for or preparing for central line placement. But you use the line you have to start fluids, maybe even pressors peripherally if needed, while waiting for that central access.
Simultaneously, as you're getting that access or someone else is, you're drawing labs. Get the full rainbow, CBC, comprehensive metabolic panel, coags, liver function tests, and especially because we're in a level 1 trauma center context, always get a type and screen or even a type and cross. You need the whole picture of organ function and backup blood ready.
Okay, and here's that tip. The thing that separates the really prepared nurse from the just following orders nurse. When you draw that rainbow, always grab a second lavender top tube for a BNP. The burger no pickle tube, as some call it. Why? Because we absolutely know, we are about to slam this patient with potentially 2, 3, maybe even more liters of crystalloid fluid. We need to know if their heart has any underlying strain before we do that. An elevated BNP tells us there might be CHF or at least some ventricular stretch. It makes us way more cautious when we hit the fluid resuscitation phase.
That's a fantastic point. But now we get to the most critical sequencing requirement in this phase.
Yeah.
The one that causes the most logistical stress, the most debate sometimes, drawing blood cultures before starting the broad spectrum antibiotics.
Yeah, the urge is just speed, right? Patient's crashing, BP's low, just give the cure. Hit them with the antibiotics. But we have to balance immediate survival needs with the long-term plan for the patient. If we don't get those cultures first, we might compromise that long-term plan significantly.
Think about it. If you start the antibiotics, the fire extinguisher, before you get a sample of the blood, you can sterilize it pretty quickly.
Yeah.
The cultures then might come back negative or show no growth. But the patient is still sick, maybe getting worse. And now the team is flying blind. They're stuck using the broadest, strongest, potentially most toxic antibiotics for longer than necessary because they don't know the specific bug they're fighting.
It's that analogy the source uses, the difference between just ocean trolling with broad-spectrum drugs, hoping you catch something, versus being able to use a handheld net to catch your specific goldfish. Getting those cultures allows us, down the line, to hopefully switch to targeted narrow-spectrum therapy based on the culture results and sensitivities. That means fewer side effects for the patient, less risk of C. diff, and, importantly for everyone, less contribution to antibiotic resistance.
But, and this is a big but, we have that hard 60-minute cutoff. The guidelines are really clear here. If you are at, say, minute 55, and despite every effort you've tried multiple sticks, maybe ultrasound guided, maybe you're waiting on the central line kit, but there is absolutely no realistic chance you will get those blood cultures drawn before that 60-minute mark hits. The priority flips completely. The instruction is give the antibiotics anyway.
This is where that real-world ED friction comes in, isn't it?
Yeah.
Let's say I'm at 55 minutes, cultures aren't drawn, the patient's unstable, A&D, a massive trauma just got announced overhead, needing my immediate attention. Am I really going to prioritize one more difficult stick attempt over getting those life-saving antibiotics started? The guidance says no. Delaying the antibiotics beyond that hour mark statistically causes more harm, the increased mortality risk, than missing the initial cultures does.
Exactly. The immediate mortality risk of delaying the cure outweighs the diagnostic downside in that specific time-critical moment. Now, ideally, in a well-oiled level 1 ED focused on sepsis preparedness, this scenario should be rare. We should have processes to get cultures quickly. But if it happens, the antibiotics take precedence. And just quickly, while we're talking labs, another useful one to grab if you can, though it's not strictly in the hour 1 bundle, is a procalcitonin, or PCT. Getting a baseline PCT can be really helpful for the team later, like 24, 48 hours down the road, to track the inflammatory response and help guide when it might be safe to de-escalate antibiotics. Just something else to consider drawing with that initial rainbow. Okay, so assuming we either got the cultures or we hit that 60-minute wall, we immediately move into phase 2. This is bundle step 3, hang the broad-spectrum antibiotics. This is the direct attack on the likely source of the whole problem, the infection itself. And it needs to happen urgently.
Yeah, the urgency. We keep saying it, but it bears repeating because the numbers are just stark. That statistic we mentioned. Every single hour of delay before a patient in septic shock gets the right antibiotics, their risk of dying goes up by roughly 7 to 8%. per hour.
Think about what that means in the ED flow. Maybe the patient waits in triage for an hour because we're swamped. Then it takes another hour to get assessed, get orders in, get access. Then maybe another hour until the pharmacy mixes the specific dose, sends it up, and we actually get it spiked and running. That's 3 hours. We've potentially just increased that patient's risk of death by something like 21 to 24% just through delays. That's a huge motivator to streamline this step.
So the infection is the fire raging through the body. The broad-spectrum antibiotics, they're the fire extinguisher. In this first hour, we don't have time to figure out the exact type of fire or where it started. We just need to pull the pin and spray, cover the most likely culprits. That usually means something for gram-positives, like vancomycin, and something with broad gram-negative coverage, like Zosyn, piperacillin, tazobactam, or, whatever your specific hospital's sepsis protocol and antibiogram recommends as first-line broad coverage.
And the reason for those specific choices, generally vancomycin or maybe a carbapenem or cephalosporin, depending on local resistance patterns, is that they cover the most common sources of severe sepsis, things like pneumonia, complicated UTIs, intra-abdominal infections, serious skin and soft tissue infections. They have good penetration into tissues. We'll figure out the specific bug, that goldfish, later when the cultures hopefully grow. Right now, we need to suppress the bacterial load that's driving that whole systemic inflammatory cascade, that cytokine storm causing the shock.
And this ties right back to that image of the prepared nurse, right? The one with the Vanic vial popped and ready. If the standard order is, say, 2 grams of vancomycin, and it needs to be mixed, maybe diluted in 250 milliliters, and infused over usually 60-90 minutes, every single minute spent waiting for pharmacy to mix it during a busy time, or waiting for it to be tubed up, or even just walking to the Pyxis to get it, those are minutes adding to that 7-8% mortality risk. Being proactive, having it ready, maybe even getting the ED pharmacist involved if they're available to start mixing as soon as sepsis is suspected, that can shave precious time off this critical step.
It really can. And we also have to acknowledge this step often happens while you're also trying to calculate and start the massive fluid bolus. It's a major coordination challenge in a busy ED room, which brings us right into the next phase, managing the hemodynamics.
Okay, antibiotics are infusing, or at least ordered and on their way. Simultaneously, we have to tackle the profound circulatory failure that's bundle step 4, fill and dilute. This is our big attempt to compensate for the body's inability to maintain its own blood pressure.
And the standard protocol here is very specific, very prescriptive. It's a rapid infusion of a large volume of crystalloid fluid, usually normal saline or lactated ringers. The dose is weight-based, and it's substantial. 30 milliliters per kilogram of ideal body weight. For an average adult, maybe 70-80 kilos, that's easily 2 to 2.5 liters of fluid. And it needs to go in fast, often using a pressure bag or even a rapid infuser device if you have one available. We're talking about getting this volume in over maybe 30 to 60 minutes, ideally.
Now, why so much fluid? We really need to understand that leaky fire hose physiology we touched on earlier. The patient is hypotensive, yes, but it's not just simple dehydration usually. It's the systemic vascular failure caused by the inflammation.
Right. It's that two-pronged attack driven by the cytokine storm. Problem number 1, massive vasodilation. Those inflammatory mediators, things like TNF-alpha, nitric oxide, interleukins, they cause the smooth muscle in the blood vessel walls to relax. The vessels get wide, floppy. Think of it like suddenly trying to fill a huge baggy hose instead of normal garden hose. The pressure inside plummets. That's a massive drop in systemic vascular resistance, or SVR. The container's just too big for the volume inside it.
And then problem number 2, capillary leak. The inflammation also damages the lining of the smallest blood vessels, the capillaries. That endothelial barrier breaks down. What should be a nice, contained circulatory system starts leaking. Plasma, protein, fluid, it oozes out of the blood vessels and into the surrounding tissues. That's called third spacing. So you see the patient getting puffy, maybe edematous, but paradoxically, the volume inside the blood vessels is actually decreasing, making the hypotension even worse. It truly is like a leaky, oversized fire hose.
So that huge 30 millikilogram bolus, the primary goal is just brute force volume replacement. We're trying to fill the tank, this massively dilated, leaky tank, enough to restore some pressure inside the system. We need to get enough volume back into the intravascular space to generate a decent blood pressure, specifically a mean arterial pressure, or MAP, of at least 65 millimilli HHE. That's generally considered the minimum needed to perfuse vital organs like the brain, heart, and kidneys.
But there's a second reason for all that fluid, right? It connects back to step 1, the lactate. The fluid helps fight the acid.
Exactly. It works in 2 ways against the lactate. First, the immediate effect, simple dilution. When you pour 2 or 3 liters of saline or LR into the bloodstream, you're diluting everything in there, including the lactic acid. So if you were to recheck a lactate right after the bolus, it would likely be a bit lower just from dilution alone.
Hmm.
That's helpful. It buys some time, but it's not the real fix.
The real fix, the more important sustained effect, comes from improving perfusion. By increasing the volume and hopefully raising the blood pressure, you start pushing more oxygenated blood out to those tissues that were starving and resorting to anaerobic metabolism. When the cells get oxygen again, they can switch back to the cleaner, more efficient aerobic pathway. They stop churning out lactic acid, so the fluid bolus helps stop the source of the acid production.
Okay, but now we absolutely must talk about the major caveat here. This step, pushing 3 liters of fluid rapidly, is not without significant risk, especially in the kind of complex patients we see in a level 1 ED. Many of our patients have underlying conditions, think congestive heart failure, CHF, maybe chronic kidney disease, CKD, or end-stage renal disease, ESRD. Pouring this much fluid into them can easily tip them into acute pulmonary edema, fluid overload.
Which makes this phase, bundle step 4, incredibly active for the nurse. This isn't just hanging a bag and walking away. It demands constant, vigilant reassessment. You have to be watching for signs of fluid overload as that bolus goes in. And we need to look beyond just, pitting edema in their legs. That's a late sign.
We need dynamic assessments. Listen to their lungs frequently. Are you hearing new crackles, especially at the bases? That's fluid backing up into the alveoli. Watch their oxygen saturation closely on the monitor. Is it starting to dip as the fluid infuses? Are they needing more oxygen? That's another huge red flag. And this is where that proactive BNP draw becomes so valuable. If that baseline BNP you drew earlier came back high, it tells you their heart might already be struggling. You need to be extra cautious with the fluids, maybe give smaller boluses, and reassess even more frequently.
But probably the best tool we have in the ED now for real-time objective fluid status assessment is bedside ultrasound, specifically looking at the inferior vena cava, the IVC. Getting someone skilled, maybe a provider, maybe an ultrasound-trained nurse, to put a probe on the IVC can tell you a lot about whether the patient is likely to respond positively to more fluid or if they're already overloaded.
Yeah, the IVC assessment is incredibly useful. You look at its diameter and how much it collapses when the patient breathes in. If the IVC is small and collapses significantly with inspiration, they're likely still volume responsive or fluid tolerant, meaning more fluid will probably increase their cardiac output and blood pressure. They need more volume. But if that IVC is fat, distended, rigid, and barely collapses at all with breathing, that suggests their central venous pressure is high. They're likely not going to benefit from more fluid, and you risk pushing them into pulmonary edema. You need to hit the brakes on the bolus, or at least slow it way down, and communicate that finding urgently. The decision to continue or stop fluids often rests heavily on these dynamic reassessments, lungs, O2 sats, and ideally, that IVC view.
And just a quick word on the type of fluid. There's always that ongoing debate, crystalloids like saline and LR versus colloids like albumin. For the purposes of the initial hour 1 bundle resuscitation, crystalloids are still the standard first choice. They're effective, they're cheap, they're readily available. While some fluid definitely leaks out due to the capillary leak, enough stays intravascular initially to help restore volume and pressure. So unless there's a very specific reason or protocol otherwise, we stick with NS or LR for that initial 30 milligram bolus.
All right, so we've hit them with a big fluid bolus, maybe 2 or 3 liters. We've reassessed. But what if their pressure is still just inadequate?
Yeah.
This brings us to bundle step 5. Squeeze the pipes with vasopressors. This is the intervention we use when the shock state persists despite adequate fluid resuscitation. When it's clear the problem isn't just volume, it's the vascular tone itself.
Right. We've tried filling that leaky, floppy tank. We gave the 30 milliliters, but we look up at the monitor, and the mean arterial pressure, the MAP, is still stubbornly below that magic number of 65 millimilli Hg. The source calls this the pucker level, which feels pretty accurate sometimes. If the MAP is still down there after fluids, the vascular system is just too dilated, too unresponsive. Fluids alone aren't cutting it. It is officially pressor time.
We need to chemically intervene to restore that lost vasomotor tone. The goal is still the same. Achieve adequate organ perfusion, reverse that cellular starvation, get them making ATP aerobically again. So we use medications, vasopressors, usually given as continuous infusion, that cause systemic vasoconstriction. That's the squeeze. Ideally, the first choice might also help the heart beat a bit stronger, the kick.
We're essentially using drugs to artificially shrink the diameter of those blood vessels, increasing the systemic vascular resistance, SVR, and forcing the blood pressure up to perfuse those vital organs, brain, heart, kidneys. Understanding the specific drugs and how they work, their mechanisms, is really crucial for us as nurses because it guides how we titrate them and what we watch for.
Okay, let's get into the specifics. The most common first-line vasopressor for septic shock is norepinephrine, brand name Levofed. We usually just call it Levo. Levofed is a catecholamine, and it works primarily on two types of adrenergic receptors, alpha-1 and beta-1.
Okay, alpha 1 and beta 1. What do they do? The alpha 1 stimulation is what gives you that powerful squeeze. It causes vasoconstriction in the peripheral arteries and veins, increasing the SVR, raising the blood pressure. That directly counteracts the massive vasodilation of sepsis. The beta 1 stimulation gives you the kick. It increases the heart rate slightly, chronotropy, and more importantly, increases the force of the heart's contraction, inotropy, so it helps the heart pump more effectively. This combination makes Levophed a great first choice because it addresses both the vasodilation, low SVR, and potentially a sluggish heart, which can also happen in sepsis.
Exactly. But starting the drip is just the beginning. This leads right into the absolute core of the nurse's role with pressors, hands-on titration. This is absolutely not a medication you just set at a starting rate and forget about. You, the nurse at the bedside, are the continuous monitor and adjuster. You are fine-tuning that dose constantly based on the patient's response, primarily their MAP.
And the precision needed here is immense.
Yeah.
You're not just trying to get the MAP above 65. You're trying to find the lowest possible dose of Levofed that reliably maintains that MAP target of 65 or slightly higher, per your institution's protocol. Why the lowest dose? Because this is a real high wire act. Too little pressor is bad, but too much pressor is also bad, just in a different way.
Right. Too little, obviously, means they stay hypotensive. Organs remain underperfused, lactate stays high, patient circles the drain. We know that's bad.
Right.
But if you crank the Levophed up too high, if you overshoot, that excessive vasoconstriction driven by the alpha effects can clamp down too hard on peripheral blood flow. You can actually cause ischemia, lack of blood flow to the fingers, toes, nose, ears, even the gut sometimes. You might see cold, mottled extremities, poor capillary refill, dusky fingertips. You've essentially traded one type of hypoperfusion for another, even though the number on the monitor, the MAP, looks good.
So it requires really careful, deliberate titration, usually starting low, maybe 2-4 mics per minute, and adjusting up or down every few minutes based on the MFP response. And documenting those changes clearly is vital. And here's a practical tip for those working in busy level 1 EDs. Learn to use your electronic charting system efficiently. If you use Epics, for example, learn the block charting feature for drips. Being able to quickly document multiple rate changes and vital signs together saves you precious clicks and minutes. Minutes you can then spend actually looking at the patient, assessing their peripheral perfusion, their urine output, their mental status, the real signs of whether the pressor is working effectively.
Great point on workflow. Now, what happens if you're titrating that Levophed up and up and up? Maybe you're getting into higher doses, say 15, 20, 25 mics per minute, and the MAP is still barely hitting 65, or maybe not even. Often, the next best step isn't just more Levophed. It's usually adding a second vasopressor that works differently. The most common second agent added is vasopressin, or Vaso.
Okay, so why add Vaso instead of just maxing out the Levo? This goes back to those mechanisms, right? Levofed works on alpha and beta adrenergic receptors. Vasopressin is totally different. It's actually an analog of antidiuretic hormone, ADH, and it works primarily on V1 receptors located on the vascular smooth muscle.
Exactly. It causes vasoconstriction through a completely separate pathway, a non-adrenergic pathway. So when you add vasopressin, usually at a fixed non-titrated rate like 0.03 or 0.04 units per minute, you're essentially attacking the hypotension from a second direction. It's synergistic with Levophed. Often, that combination of moderate dose Levo plus low dose Vaso can achieve the target MAP much more effectively, and sometimes with fewer side effects than just pushing the Levophed dose sky high.
That makes sense, using two different tools for the job. But now we have to talk about the big, scary risk with these drugs, especially Levophed, tissue toxicity if it leaks out of the vein, extravasation.
Yes, this is critical. Vasopressors, particularly potent alpha agonists like Levophed, are incredibly damaging to surrounding tissue if the IV infiltrates. That intense vasoconstriction can cause severe tissue ischemia and necrosis tissue death. It's devastating. The absolute standard of care, the policy everywhere, is that continuous vasopressor infusions must be run through a central line as soon as possible. A central line ensures the drug is delivered into a large, high-flow vein where it's rapidly diluted, minimizing local effect. And if you do that start levo peripherally, you absolutely must mitigate the risk. First, choose your site wisely. Use the largest vein possible, ideally in the forearm or the antecubital fossa, AC. Avoid hands or wrists if you can. Second, You must assess that IV site relentlessly, like visually inspect and palpate it every 5 to 10 minutes initially, then maybe every 15-30 minutes once stable. Look for any signs of infiltration, swelling, coolness, pain, blanching, redness. And third, you need to know your hospital's extravasation protocol cold. Specifically, you need to know about the antidote, phentolamine, brand name Region agent.
Phentolamine, right, it's an alpha blocker. If levodopa leaks out and starts causing vasoconstriction in the tissue, injecting phentolamine around the site can counteract that alpha effect, hopefully restoring blood flow and preventing necrosis. Knowing the dose, how to dilute it, how to administer it, and having the kit or medication readily accessible. That's part of being prepared to use peripheral pressors safely. We accept the risk of peripheral administration because ongoing, profound hypotension is definitely more harmful than the potential risk of extravasation. But we have to be hypervigilant about managing that risk. Okay, whew. We've walked through step 0, think sepsis, all the way through bundle step 5, the pressors, all needing to happen ideally within that first hour. It's a complex, multi-pronged attack plan against a rapidly evolving enemy. And when you lay it all out like that, what becomes incredibly clear is just how central the nurse's role is in all of this.
Absolutely. It's definitely a team sport, right? You need the provider for orders and procedures, maybe respiratory therapy, managing the vent, maybe pharmacy, mixing meds. But the person who is orchestrating and executing the majority of these critical, time-sensitive interventions at the bedside, that's the nurse. You are the engine driving this bundle.
Think about it again. It's the nurse doing that initial subtle recognition, trusting their gut. It's the nurse fighting for that critical IV access. It's the nurse drawing the labs and cultures in the correct order under pressure. It's the nurse calculating the fluid dose, hanging the bags, often on a rapid infuser. It's the nurse verifying and hanging the first dose of antibiotics. And crucially, it's the nurse who is standing there, eyes glued to the monitor and the patient, making those constant, precise adjustments to the vasopressor drip, using clinical judgment every step of the way.
Without that skilled execution, without that ability to multitask 5 critical things at once under immense pressure, the best sepsis protocol in the world is just ink on paper. It's your preparation, your vigilance, your hands-on skill that actually translates that protocol into improved patient outcomes. It's what allows the whole team to hopefully stop sepsis from causing any further harm in that first absolutely defining hour. Honestly, it's why we do what we do in the Level 1 ED, isn't it? Hashtag tag outro.
Well, that brings us to the end of this deep dive into mastering the Sepsis Hour 1 bundle in the Level 1 ED. We really tried to hit that mindset shift, recognizing sepsis as this systemic war. We dug into the why behind lactate as a measure of cellular suffering and stressed that critical sequence, cultures before antibiotics, unless you hit that 60-minute deadline.
Yeah, and we unpack that leaky fire hose physiology to explain the massive fluid bolus, but also emphasize that crucial need for constant reassessment, checking lungs, SATs, and ideally using IVC ultrasound to avoid fluid overload. And finally, we got into the weeds of pressor management, that high-wire act of titrating level fed, understanding its alpha-beta action, knowing when and why to add vasopressin with its different V1 mechanism, and always being vigilant about the risks of extravasation.
So as you head back out there, maybe enter your next shift, we want to leave you with one final thought, something to chew on, connecting what we discussed to your practice.
Thinking about those pressor mechanisms. How does really understanding the difference between how levofed works, hitting those adrenergic alpha and beta receptors, and how vitressin works on totally different V1 receptors? How does that knowledge influence your thinking? Specifically, when you have that patient who's still hypotensive after fluids, maybe you've started levo peripherally because you don't have central access yet. Are there specific clinical signs or patient factors that might make you think about suggesting or reaching for vasopressin sooner, even before you've pushed the levo dose really high? What stands out to you now, knowing those different mechanisms?
Something to think about. Consider that interplay between the drugs next time you're in that situation. Thank you so much for joining us on this deep dive today.